Hi, welcome to today's webcast, Medication Risk Management in Senior Living. I'm Lois Bowers, Senior Editor of McKnight Senior Living, and I'll be your moderator. Medication management is an area of risk for all senior living providers. Whether your community is providing basic medication assistance with the typical tablets and liquid medications, or you are involved with the more complex administration of injections and treatments, your residents could be in danger if your medications are not managed appropriately, and your community could face the risk of legal liability if mistakes are made. So we're pleased to have Josh Allen, Vice President of Quality and Compliance for Senior Resource Group, with us today to share strategies to reduce the risks associated with medication management. We'll hear from Josh in a few moments, but first we have some housekeeping matters to take care of. First, I'd like to let you know that today's slides are available for download. To download them, please see the Event Resources area on the left side of your screen and then click on the PDF. And if you think you're experiencing audio difficulties with this broadcast, please first check the volume control on your computer. We found that this is the most common cause of hearing issues with presentations like this. The sound should come up on your computer speakers. If the volume control doesn't appear to be an issue, then please click the Help button at the upper right of the player for assistance. Please also keep only one browser window open on your computer to prevent echo. Also, we'll have time for questions and answers at the end of today's presentation. So if you have any questions about the information presented, please feel free to send them directly to us at any time during this hour by clicking the button and typing them. This educational offering has been reviewed by the National Continuing Education Review Service of the National Association of Long-Term Care Administrator Boards. It has been approved for 1 clock hour. Please note that you must stay tuned to this event in its entirety during its original broadcast to receive a certificate. We'd also like to note that this program is made possible by support from Omnicare, a CVS company. Please visit its website at omnicare.com. But remember, do not interrupt this webcast presentation if you would like to earn the CE credit. Finally, this session will be archived and available on demand shortly after this live broadcast. You can access the webcast again at no cost, and others can experience it for the first time, again at no cost, by simply going to the registration page to enter this studio. The web address is mcknightseniorliving.com/May11webinar. As I mentioned, however, accrediting bodies dictate that CE credit may be given only for attendees at this live broadcast. Now I'd like to tell you a little bit more about today's featured speakers. As I mentioned, Josh Allen is Vice President of Quality and Compliance for Senior Resource Group. Josh is a registered nurse with more than 20 years of experience in senior living, having held executive leadership positions for operators and developers, where he had responsibility for clinical services, regulatory compliance, and staff training. Josh is educated and consulted with thousands of senior living professionals, and he has served as an expert witness on legal matters involving assisted living standards of care. He holds a certification in assisted living from the American Assisted Living Nurses Association, serves on the board of the directors of the California Assisted Living Association, and is a past board chair of the Center for Excellence in Assisted Living. We're also joined by Nancy Losbin, consultant pharmacist and chief quality officer for Omnicare, a CVS health company. In addition to being a certified consultant pharmacist, Nancy also holds certificates in gerontology and pharmacy regulations, and she is an adjunct faculty member at the University of the Sciences in Philadelphia. Nancy is a fellow of the American Society of Consultant Pharmacists and serves as chair of the organization's Antimicrobial Stewardship Steering Committee. Additionally, she chairs the ASCP Foundation. Nancy also is a member of the Clinical Practice Guideline Committee of Amba, the Society for Post-Acute and Long-Term Care Medicine. With that, I'm going to turn things over to Josh, who will begin the presentation. Josh?
Good morning, everybody, or good afternoon, I suppose, depending on where you're at in the country. The a pleasure to be here. Looking forward to talking with you guys for a little while about medication risk management in senior living. As you heard from Lois, I've worked for a long time in the senior living industry, really my entire nursing career, and I've watched our approach to medication management evolve. I can remember when I first got started in this business, we were sort of drug kicking and screaming into medication management. You know, we sort of saw it as the medical side of our business, and maybe a lot of us were worried about all the risk related to it and the challenges and dangers. And today we can continue to be concerned about that risk, but we realize that it is a vitally important part of the services that we provide to our residents. In fact, studies show that 80% of assisted living residents require assistance with medication management. Of all of the routine daily activities that we assist our residents with, it's in fact the most common. You compare it to bathing, for instance, about 62% of residents need help with bathing, dressing 47%, toileting 40%. So there's a lot we do for our residents day in and day out that is hands-on in nature, but handling their medications is really among the most common. And we also know that assisted living residents are taking a large volume of medications. In fact, on average, residents living in assisted living take more medications than their counterparts living in skilled nursing facilities. The average number is 9 different prescription medications, and of course that doesn't necessarily take into account over-the-counters and of course medications that are taken on a short-term basis, but an average of 9 routine medications. So if you do some simple math, like if you have a 100-bed assisted living or senior living community, 80% of those people, so 80, I chose easy math because it's not necessarily my strong point. So you got 80 residents in that building taking an average of 9 medications. That's 720 medications that would have to be passed in any given day to those residents. And so it really, I think, puts in perspective just the overwhelming volume of the task that our staff are faced with in senior living communities every day. And for those of us on the line that spend our time in communities and have, like myself, been in medication rooms. I've been in 3 different med rooms this week alone. We recognize the challenge our staff face. The daily work involved to stay on top of medication changes, to deliver medications in a timely manner, to handle resident questions, family questions, doctors that they have to get a hold of, dealing with refills, dealing with changes. I mean, there's just simply a lot of work to do to deliver those medications on time to the right resident via the right route, stick to those 6 rights every single time they're handling a medication. What's, I think, though, most interesting is our staff do an amazing job at conquering that big task. Studies show that 35% of medication administrations in assisted living involve an error. And at first, I'll grant you, that sounds pretty bad. The idea that over a third of medication administrations would involve some sort of error. But it's important to note that this same research, which was done at the University of North Carolina, found that 71% of errors are related to timing of administration, which again I think speaks back to the volume. And we're going to circle back to this issue of the volume of medications in a little bit. But if you take away the errors related to time, and I think there's some things we can do to control for that are relatively simple and low cost to us from an operational standpoint. Only 3% of errors in assisted living are shown to have moderate or significant risk of harm to the resident, which is not to suggest that any error is acceptable. We certainly want to take that approach in our communities that no medication error is ever okay, but we actually have a relatively small percentage of errors that have the potential to harm our resident. So while we're going to share some strategies today on what you can do to even further control your risk, the first thing I want to suggest to you is that you should be proud of the amazing job we do now. That while there's always room to improve, we do a really good job of managing a huge volume of medications in our communities today. In what in the past was considered maybe sort of the more medical, if you will, side of our operations, we've really, as an industry, done a very good job creating systems and procedures, and even to an extent, state regulations that help to ensure that medications are delivered according to those 6 rights. They are delivered correctly, and it's done in a way that has a low risk of harm to our residents. But that's, of course, not to suggest that everything is perfect. And our goal today is to look at what can we do with those errors that do have risk for harm. What can we do to control our risk, both to the resident and to ourselves as providers even further. What I would suggest to do is to focus on 3 steps we can take to manage our risk related to medications. Those include, number 1, focusing on the high-risk medications. Again, if 3% of errors had risk for harm, let's focus in on those. Let's look at those medications our residents are taking and what we can do to manage those medications in absolute adherence to the 6 rights. Number 2, implement systems to address this issue of the volume of medications. Again, that huge number of pills and tablets and liquids and ointments that our staff are having to manage on a daily basis. Having good systems in place is absolutely critical to being able to successfully handle that volume of medication delivery that our staff face every day. And third, addressing the issue of narcotics. And I highlight this because in my practice, where I have the opportunity to work with hundreds of different communities around the country, we have noticed in the last several years a real uptick in issues related to the control of narcotics. Just yesterday, in fact, I was reviewing with a community here in California that had 2 entire containers, bubble pack sheets of narcotics go missing. And that's something that puts obviously the resident at risk of not receiving the medications they need, but it puts us into real potential legal peril if we are not safely managing these medications that are both a significant risk of misuse, and let's face it, they have a high street value, and there are serious issues related to diversion with our staff who handle medications. We've even heard stories of people coming in and robbing communities at gunpoint just to get their narcotics. Someone's friend who works in the community has a friend of a friend who maybe isn't of the highest moral character, and they're out there looking for those types of drugs. They find out that there's this nice little senior living community across town that has a whole bunch of these medications in their bedroom, and other than a key to get into them, really not a whole lot of other safeguards in place, and it makes us a target. So again, focus on high-risk meds, implement systems so that you can handle the volume of medications, and then thirdly, put in some controls relative to narcotics. And for the rest of our webinar today, we'll dive into each of these areas.
I'd also like to bring to your attention that at times it's not just the medications that have already been dispensed, but we also have to be very cautious about controlling the written prescription for controlled substances until it is brought to the pharmacy or submitted to the pharmacy for it to be filled. You don't need one of your employees to take a written prescription for a controlled substance to a local drugstore and have it filled on behalf of the patient and yet take the medication home with them. Thanks, Josh.
Yeah, that's a really good point, Nancy. I mean, the bottom line is when it comes to narcotics, and we'll dive into those some more in a little bit. People get creative, whether it's because they have an addiction issue and they're trying to get the drug for themselves, or if it's financially motivated because of the street value of the medications. People in either scenario, they will do things that will shock you. The creative ways they come up with, replacing medications with things that look similar, messing around with the prescriptions, as Nancy described. I mean, there's just all kinds of things we've found people will do in order to misuse those narcotics. So absolutely, we have the sort of constant challenge of trying to stay one step ahead. So let's start by talking about what we can do relative to the issue of these high-risk medications. Again, if it's 3% of those are putting our residents in danger, let's narrow our focus into those issues before we start to sort of try and tackle the bigger mountain in front of us. And there's lots of different ways to look at what exactly constitutes a high-risk medication. There is, for example, the Beers criteria that we're all familiar with that gives us guidance on medications that should be avoided in older adults. But what I'm really talking about isn't necessarily medications that should be totally avoided, but medications that are a necessary part of treatment, but nevertheless put the resident at risk. There was a study that was reported a number of years back that found that 1/3 of emergency room visits by older adults related to an adverse drug event were caused by 3 medications. So if we can say, okay, let's start with those 3 medications: Warfarin, insulin, and digoxin. And anyone who spends any amount of time in a senior living community knows that those are 3 medications we come across in our resident population all the time. So what can we do to address each of these? Now, of course, these suggestions assume that we are working with the prescriber or the physician to ensure the right medication is being prescribed to treat the right issue. Assuming that's in place, we've got a resident who's going to be taking Warfarin or Coumadin, or really any other sort of blood-thinning medication. What are some of the things that we should consider? Well, number one, we have to have some sort of system in place to ensure appropriate lab monitoring and then appropriate adjustments of medication dosage when those lab values necessitate it. So having a system that ensures that we have a schedule of how often the resident should be going for their lab testing, and we have a system to ensure that those lab results are reported back to the physician. Again, in the past, I think we as providers sometimes took too much of a hands-off approach, that we'd let the family, take them to the lab, and we would assume that the family was talking to the doctor, and we would just sort of sit back and wait for someone to get a hold of us and tell us there's been a prescription change. We really, we can no longer do that. We really have to take an active role to ensure we understand what is the frequency of lab monitoring that is being recommended, ensuring that we have a schedule in place, and even down to the level of transportation. How is the resident going to get out to have that lab test done, have that blood drawn? Then when those results come back, ensuring that they're communicated back to the prescriber. There have been some real unfortunate circumstances where a resident went out, got their blood drawn, had their PT-INR done. They brought the results back. The results were actually of significant value, needed a medication adjustment, but those results were not relayed back to the physician until some days later, and the resident had significant adverse effects, bleeding out, etc. So having a procedure in place. In our communities, we use a simple one-page document, a simple form that we call our Coumadin tracking log. And it's a running report that shows us the the date and time of their most recent lab result, yes or no if the physician ordered any medication changes, and then the date and time of their next lab test, whether it's monthly or bi-monthly or whatever the frequency for that particular resident is. We know all of our residents who are on Warfarin or other blood thinners, and we use that simple piece of paper in their chart to track and stay on top of getting their lab tests done. We also know, of course, residents taking Warfarin may require dietary modifications. There are certain foods that can increase or decrease the blood thinning effect of medications like Warfarin. So we should be sure we're speaking with the physician about those dietary modifications, and that, again, we have a system in place to communicate them to your dining or food service department. Keeping an eye on over-the-counter medication use. Of course, one of the real challenges we have with residents taking Warfarin or other blood thinners is, they go out to the drugstore, they go out to the grocery store, they buy themselves some over-the-counter medications like good old aspirin, and we know that there can be serious risk of taking those medications together and causing the person to have a high risk for bleeding. So, speaking to residents who are on Coumadin or Warfarin about over-the-counter use, that we don't want them to go buy over-the-counter medications, that we should run any medication they're going to take through the physician, which, of course, is a general rule for any resident, but particularly important if the person is taking Warfarin. We can also educate other staff members and departments in the community to help us monitor this over-the-counter use. And here I'm thinking about housekeeping. They are going to be in those resident rooms or apartments with great frequency. They're going to be helping to perhaps do laundry or put things away, clean up the kitchen. They're probably going to notice before, certainly, us as the nurse, they're probably going to notice a bottle of aspirin or other medication sitting on the resident's counter or in their bathroom or, being kept in a dresser drawer. So we've made it a practice to educate our housekeeping staff as well as our maintenance staff. We're not asking you to go and do room-by-room medication inspections, but when you're in a resident's apartment, take a look and just, be mindful. If you see medication containers, we don't want you to do anything about it. We don't want you to throw them away or try to confiscate them, but we want you to come back and let the nurse or, whoever oversees your health services department, we want you to come back and let the nurse know, and then we'll take appropriate action. Lastly, when a resident is taking Warfarin or any other blood thinner, it's important to stay on top of our fall response protocols. Certainly, any time a resident falls, we have to be mindful of the potential for injury, but we can't emphasize this enough when a person is taking Warfarin or some other blood thinner. The chance that their fall could lead to more serious internal bleeding and risk is much, much greater. And I'll share with you a real brief story. A situation I encountered in a community in Tucson, Arizona, probably 10 years ago. There was a resident who was being assisted to ambulate down the hallway. And there's a number of sort of good learning lessons here from this story. The caregiver was assisting the resident to ambulate using their walker, but it was one of those, Cadillac walkers that has the brakes and the little bench seat on the walker, the four wheels, the type I'm talking about. They're pretty universal these days. The problem is they didn't have the resident walking with the walker. They had the resident sitting on the bench, and they were pushing the resident on the walker, which I know this is a medication webinar, so I don't want to get sidetracked, but I can't emphasize enough, that is not how those are meant to be used. Those walkers are not meant to be used as wheelchairs. Nevertheless, they're assisting this resident to sort of be pushed down the hallway on this walker, and they went to a section in the hallway that went from carpet to tile. So there was that little, threshold, that little lip between the carpet and tile. As they pushed the walker over that lip, it got hung up and it tipped over. The resident fell backwards because they were being assisted inappropriately. They fell backwards and they hit their head on the hard tile floor. Resident, was relatively unscathed in the fall, didn't lose consciousness, said, I'm fine, I'm okay. There was a little cut on the back of his head. The caregiver and the medication aide, their first response was, Mr. Jones, whatever his name was, we'll change the names to protect the privacy. Mr. Jones, I really think we should call the doctor and make sure that everything is okay. No, I'm fine. Just leave me alone. Let me go lay down and I'll feel better in a little bit. Well, unfortunately, they complied with the resident and they let him go to his apartment and lay down for a little bit. Long story short, family comes to visit about 24 hours later. Resident is still in his apartment, in his bed, and he's unresponsive. They call 911. He's taken to the hospital, and within another couple days, he's dead. He was having internal bleeding in his brain. He had a subdural hematoma. When his head smacked the ground, it damaged some of those small blood vessels in his brain, and because he was on Warfarin, he had a hard time clotting to close off those blood vessels, and so blood was slowly leaking into his brain and into his skull. That pressure increased. He lost consciousness, and eventually he died. And there are a number of things we can learn from that scenario. Number one, you don't assist residents with a walker by having them sit on the bench. Number two, whenever a resident falls and there is head injury, and this is the key point here, whenever the head is involved in the fall, they absolutely have to be evaluated by an appropriate professional in an appropriate medical setting. And we don't have the tools, we don't necessarily have folks with the right skill set to conduct the appropriate assessment for something like subdural hematomas. We absolutely have to get those people out, and certainly even more important if they're taking Coumadin. Additionally, after any fall, we should be doing routine checks of that resident status. We generally recommend every 2 hours for at least 72 hours, so that we could have gone in and seen, hey, Mr. Smith still isn't wanting to get out of bed. I'm a little worried about his responsiveness. I'm calling 911. So, really those concepts apply to any resident, any situation, but particularly if you have a resident taking warfarin.
Two things in addition to that, Josh. If you are using a warfarin monitoring sheet, the target INR for your resident should be somewhere on the sheet so that you can address that with the recent lab value that was returned by the lab with the prescriber. Most of our residents will have a target INR of 2.5 or 3. All INRs should be applied as critical labs in your community and discussed with the physician or prescriber the same day. In addition to that, if you have non-compliant patients or you have frequent flyers, it may be beneficial to find an alternative anticoagulant other than warfarin that may be appropriate for the condition that's being treated. Thanks, Josh.
Yeah, absolutely. Great point, Nancy. Again, we want to create that visibility for our staff that as I said earlier, we're not just turning over management to the family and the doctor and, someone let us know. We're really being an active participant in managing that resident's warfarin. And I think Nancy makes a great point that when possible, let's get them off that medication onto something with a little bit lower risk profile. Our second high-risk medication we mentioned was insulin. And I think there's a number of things to think about here, including the resident's ability to administer that insulin. But before we even talk about that, I want to really emphasize a point that I think is far too often overlooked, and that's that sliding scale insulin is not a recommended therapeutic approach for the population of residents being served in the typical senior living community. And by typical, what I'm talking about is, 80 to 85 years old, multiple chronic health problems. In fact, we know that half of our residents have 3 or more chronic health problems. In fact, very specifically, this isn't just Josh saying this here. The American Medical Directors Association, or Amba, has a number of position statements relative to care of residents in the long-term care setting. And number 2 of their, I believe they have 10 different position statements. Number 2 is don't use sliding scale insulin for long-term diabetes management for the folks that we're serving. The reality is the risk-benefit profile just doesn't support it. That we know that someone on sliding scale insulin is more subject to fluctuations in blood sugar. They're likely to be under more prolonged hyperglycemia. They're at a greater risk of hypoglycemia if they don't manage it appropriately. There's increased discomfort and non-compliance with self-monitoring of blood glucose. And the reality is, something along the lines of basal insulin, or perhaps a basal bolus where you take a basal insulin and then you take a rapid acting with meals without doing the sliding scale. It's going to give a more consistent control of their blood sugar that mimics normal physiologic insulin production. And really sliding scale is a more aggressive approach to managing diabetes in persons who are younger in age and looking at the long-term consequences of mismanagement. When you're talking about someone who's 80 to 85 years old, the benefits of that aggressive approach really are just no longer seen. So the first thing I would really encourage everyone on today's webinar to do is go back and look at your resident population that's taking insulin. And if you have anyone on sliding scale, go back and speak with their prescriber or primary care provider. We really want to talk with them about why are we using sliding scale? Is it really beneficial? Is it really necessary? Given the profile of the individual that we're caring for. With that said, whether or not they're on sliding scale, if the resident will be using insulin, it's obviously important to consider who is going to administer that insulin. And this is going to vary quite a bit from state to state. In some states, medication aides or techs are allowed to administer injections under either a nurse delegation or perhaps a state certification approach. But of course, when possible, we really want to encourage the resident to self-administer. Now, of course, anytime a resident is going to self-administer their insulin, you want to have the authorization for that in writing from the physician or from their primary care provider. But I think it's also a good practice to do your own evaluation of the resident's ability to self-manage their medication. This is really, I think, true of all medications, but particularly something as potentially serious as an insulin injection. What I have on the screen, and I'm not sure how well you guys can read that little screenshot, it's a simple form that we use to assess the resident's ability to self-administer. And you can see it's just 4 or 5 very, very easy questions. It's things like, can the resident read the medication label? Can the resident draw, pour, etc., the medication? Can they accurately demonstrate their ability to self-administer? Can the resident self-report any problems or adverse effects from the medication? So simple questions. Really only takes a few minutes to sit there and watch the resident take their insulin and do a return demonstration. But it gives you a tool you can use to document that in the resident's record, and then you can make this a part of your routine assessment of your residents, whether you're doing that quarterly or semi-annually, or upon change in condition.
Once we're able to stabilize a resident's insulin regimen, whether it's through the assistance of their attending physician or even an endocrinologist, it also will eliminate the number of finger sticks that have to be used because the sliding scale is no longer appropriate. And that also will minimize the risk for the community itself when there's less work to do and now can concentrate on other areas of medication management. In addition to that, for residents who self-administer, insulin pens may be a better option than using a vial and a syringe.
Yeah, great point on the pens, and I'm remiss for not mentioning that. You really do not want your residents using the old-fashioned vial and syringe unless for some reason it's absolutely necessary. The pens are, really from my perspective, one of the greatest advances in insulin therapy in recent years. They make it so much easier to dial up and administer that dose, much lower risk of error. They also help to keep the resident independent. It can be hard with those 80-year-old hands and fingers, especially if you've got some bit of Parkinsonian tremor or some failing eyesight or dexterity issues going on. It can be really, really hard to draw up a dose using one of those tiny insulin syringes. So definitely the pen when possible. And even if you're in a state where your med aids or techs are allowed to administer injections, again, I would really encourage to stick with the pens for them as well. It's easier, it's more efficient, and there's a lower risk of error. I know there are, in fact, a few states where med techs are only allowed to administer an injection if it is using the pen device. We should also mention, before we go on, I'm trying to keep an eye on time here, but we should also mention not to overlook your other approaches to managing blood sugar, good old-fashioned diet and exercise. And those aren't always easy, and residents are not always as compliant as we would like them to be. But they're highly, highly effective, particularly, of course, if we're talking about a type 2 diabetic, which is the overwhelming majority of our residents with diabetes. Ensuring they're on a diet that fits what their primary care provider has recommended. Making sure we understand how to implement the diet, so involving the help of a registered dietitian where you can. And then keeping our residents active. And that doesn't have to mean spending 20 minutes on a treadmill. It can just be part of your regular program of activities that we have walks, we have gardening outside, we have chair exercises, we have dances. I'm a nurse, not an activity director, but there's lots of things you can do to get those residents up and moving that don't necessarily feel like exercise, and the benefits you can have in terms of blood sugar control through regular exercise combined with a focus on diet. We just can't forget how highly effective that is. Granted, it takes more time to do those things than administer an injection, but the benefits are just significant. So our second point was to make sure we have systems in place that address the volume of medications. Again, the 80% of our residents need help with meds, and on average, they're taking 9 medications a day. It's a huge, huge mountain of work for our staff to overcome. So there's no way we're going to cover in a short webinar everything you would need to have in a thorough medication management system. But I would first just stress it has to be a system. You can't leave it for staff to figure out. If you're managing multiple communities, I would encourage you not to just have each community using their own system. That's where we certainly have had a lot of success working with our pharmacy partners so that we can have consistency from day to day and from community to community. The way we do it in community X is the same way we do it in community Y. And what I really want to do is kind of focus in on some areas where I think there's a greater risk of of problems or gaps, and that's orders, medication reconciliation, staff communication, and then the use of med-aids and techs. So let's start by talking about orders. You don't need to come on this webinar to have me tell you that any medication you are assisting a resident to take should only be done under an appropriate physician order. But I'd be remiss not to say it. That includes obviously your prescription drugs. It also includes your over-the-counters, whether it's, acetaminophen, aspirin, vitamins, whatever it is. We want to have an order for everything. And that's, number one, to protect the resident so that we know they're taking things they should be taking. Number two, it's to, frankly, protect ourselves, that if we're helping them to take something, we're only doing it because we've been instructed to do so by an appropriately authorized prescriber. I'm really trying to get out of the habit of saying physician, because, of course, it could be more than physicians that are prescribing medications. It could be your nurse practitioners, your physician's assistants. One tool that we find very helpful, and again, I know it's just a small screenshot here, but if you download the handouts, as was mentioned by Lois earlier, you can get probably a clearer picture of these screenshots. We use a standardized admission orders form, and there's all sorts of different ways you could approach it. But the key point being, when residents come into our community from day one, we want to make sure we have clean orders before we start handling those medications. And, some of the things we see residents come in with, especially if they're coming from home, I literally one time had a resident who was moving in, had a paper grocery bag that was filled to the top with bottles of medications. And as we dug through them, some of those bottles, they were so old that the labels were peeling off. We opened some, and it was like a bag of Skittles. There were red ones and blue ones and green ones and white ones and all kinds of different pills in these bottles. They were an absolute mess. So that you want to make sure you start day one clean and accurate. What should they be taking? Let's make sure we have that on hand. One of the things we've incorporated into our admission orders form is a sort of list of standing orders. We don't really use true standing orders in most senior living communities. We want individual orders for each resident. So we have on the second page of this sheet, it's just a list of all the common stuff. So there's like an order for their annual flu vaccine, there's Tylenol, Milkamag, and then there's room to add any additionals. So that if we've got a resident, even if they're not using these things routinely, we've got the orders on hand. We also, of course, need to make sure we stay on top of new orders and refills. And this is an area where, unfortunately, in my career doing some work as an expert witness, I've seen some real horror stories where a refill wasn't obtained, or a new order was written, but we didn't get it from the pharmacy. And this is where you frankly get a lot of back and forth between the prescriber, the family, us as the senior living provider, our poor pharmacies that get beat up over these things. And there's a lot of finger pointing. Well, I thought you were going to get it. Well, I thought you were going to get it. Oh, I sent it to the pharmacy. They never sent us the medication. Having a simple tool like this, where you're listing anything that you have as a new order or anything you've requested as a refill, this would, of course, be things that are not part of your regular cycle, obviously. But just keeping track of these things. The way we do it is kind of old school, but we literally have this piece of paper on a clipboard hanging in the med room, and we keep track. Date ordered, name of the resident, pharmacy notified, family notified, and then we have a column for date received. So you can just simply keep track. We requested this on today, the 11th, and so if by tomorrow, the 12th, I'm back at work or I'm the med-aid the next day, I can look at this sheet and say, hey, we should have gotten that refill. What happened? And I can start, calling the pharmacy and figuring out where that refill might be. It's also good to have a tool that encourages communication between your various folks who are handling medications. So whether that's med techs, nurses, or some combination. And again, it's a little old-fashioned pen and paper, but we use a tool like this where on every shift, we can keep track of just any issues that have come up. So this is not narrative charting. This is not where you would go in and make full narrative notes. This is just stuff where from one med tech working the AM shift to the next one working the PM shift, I could say, hey, I ordered that refill. Pharmacy still hasn't gotten it to us. They said we'd get it by 3 p.m. Make sure it comes in. Call them if it doesn't. Whatever. It's just a simple way to keep track of things. It also keeps track, again, maybe a little hard to read, but at the top, it keeps track of any new move-ins, any residents who have been discharged, so either they're in the hospital, they've moved out, or there's been a death, and then anyone who is on alert charting. So just a simple tool. We keep it in a binder, keep it by day and shift. We make our notes in there, and from shift to shift, we can use this just to kind of keep track of what happened on our shift and make sure it's communicated to the next. There's many shifts where there's very few notes. If everything went well and the day was uneventful, we keep it simple. The last issue we mentioned, we kind of started with earlier, was handling your controlled substances or your narcotics. And, to be perfectly honest, there's no real magic here. It's the stuff that we've been using as part of good medication management for a very long time. Having appropriate security in place. So what does that mean? That means that, of course, you keep narcotics under a second lock, and the keys to that second lock are kept with the nurse or med aid or med tech on shift at all times. The keys are not kept in a drawer. They are not hanging on a hook. We don't pass them off to someone else, so we can go take our break. Anytime those keys change hands, we should be documenting that on a narcotic shift book. So we always know who had control. So when if I'm coming off shift and I'm going to be passing the keys off to the next shift, we would go to the book and we would both sign off. All narcotic counts are accurate and accounted for, and then we would date and sign. I would sign as the person going off, and the next shift would sign as the person coming on. And then, of course, you have your narcotic count sheets for your individual medications. But that needs to be part of your routine shift pass-off, that they go through each narcotic sheet, they ensure that the count is accurate, and then they sign off that the count was accurate and that they've exchanged the keys. If you have those systems in place and they're being followed, anytime something is missing or unaccounted for, you should be able to get to the bottom of it. And so that community I told you I was working with yesterday that had 2 entire containers of controlled substances go missing, if they had been using appropriate count sheets and then shift count records, we could easily figure out who was the last person to have a good count and who was the first one to have a bad count, and we could start to make some sense of what's going on. And then, of course, do your appropriate investigations and disciplinary actions and reporting to your state agencies. So there isn't some new sort of magic cure to this problem. It's just making sure you have those systems in place and then making sure you audit them routinely. We encourage our communities to audit all of these systems, including the controlled substances, on a weekly basis. And it's not a long process. It takes maybe an hour. We go through, we check MARS, we check our shift counts and count sheets. We do a very simple med cart and med room audit to make sure everything is properly secured and organized. And then it gives us an opportunity to make corrections from a QI standpoint on a routine basis.
The off-going medication aide should be reading the number remaining for each medication from the count sheet. the oncoming or receiving medication aide should handle the package of medications and verify the number that they are receiving. So there is a system and a process to this, and it should be part of your policies and procedures.
Absolutely, and to that point, Nancy, it's surprising to me how often we take for granted that staff understand that. As a nurse who's been around medications for a long time, we all kind of get it. It was probably part of our nursing school training. But if you've got a med aide or a med tech who's new to your community or new to your organization, don't ever assume that they understand that the procedure Nancy just described. It's so simple, but it's really important that you do it the way that she just described, because that's going to ensure that the counts are correct and ensure that everyone is documenting what they see, and obviously, if there are discrepancies, that they can be resolved. So as part of your orientation training process, you want to make sure that you're getting down to the level of those details. That let's go through how we do a shift count, and make sure they really understand the process. It's always surprising to me how quickly time flies during these webinars. I feel like medications is something we could talk about, almost to no end. But I know we wanted to save some time for Q&A, so I'll turn it back over for that.
Yes, thanks for all the great information, Josh and Nancy. We've had several questions come in, and I'd like to remind listeners that if you do have any questions, please feel free to type them in, and we'll try to get to as many as we can. First question we had is, are there any tips you can share for those in independent living?
This is Josh. That's a great question. It's funny. We look at the evolution of independent living, and I'll tell you, at least from the communities I go out there and have an opportunity to see, those independent residents are looking a lot more like the assisted living resident of maybe 10 years ago. They're no longer the resident playing tennis in the morning and swimming in the pool in the afternoon. They are the person on the cover of our brochures. They are increasingly dependent, and medication is definitely one of those areas. So just three quick comments, and I'm sure Nancy may have some thoughts. Number one, kind of probably obvious, but don't get involved with medications beyond what's allowable in your state regulations. That you want to be very careful that you're not doing anything for an IL resident that would be prohibited, and would start to get you into the area of needing to be in a licensed, AL or other settings. So just make sure you have good knowledge of what your state requirements are. For example, here in California, in IL, we pretty much have to be hands-off. Number two, find good partners, and that could include home health or home care agencies. Again, within your state guidelines, but we've had a lot of success by having home care providers be on site to provide assistance with medications. It's not going to probably look like assisted living where you would have a med room and all that kind of stuff. It's more of a one-on-one where a med aide or a nurse, or I should say, a home care aide or a nurse would go into the resident's apartment and assist with medications one-on-one. But we've had a lot of success with those partnerships. Additionally, partnering with your pharmacies, and I'm sure Nancy can probably touch on this, but I know many pharmacies, including Omnicare, just to pick on them, are looking at how to create solutions for the IL setting. We've had examples where, for instance, the pharmacy will deliver medications directly to the resident apartment and put IL residents on what is, in essence, a cycle fill. But it's being done directly to their apartment, because we do have issues with meds being dropped at our reception desks in IL that we're not always real fond of. And then my last comment is look at technology. And there's no perfect system out there in my experience, but we're seeing more and more of these medication reminder and delivery systems coming onto the market. Most of us, and I don't mean to pick on one brand, but it's just the one I'm most familiar with. Most of us have seen like the Philips Lifeline product, where it's a tower of medications that automatically reminds residents to take it, and then they push a button and it dispenses the medication. But there's a lot of other products like that coming onto the market. I was recently at the Argentum conference and going through the trade show hall. I was surprised at the number of different things coming online that are designed to help someone stay independent. So those are three tips I would share.
The other thing that our independent residents can do, or we can help them do, is assure that one practice of polypharmacy is not followed, and that is that they use a single pharmacy to have all of their prescriptions filled. So at least the pharmacist can keep an eye on the patient's profile. And as you do your annual visit or assessment with independents, you can assess their ability to continue to self-medicate. And, of course, whether they're in independent living or not, we must all have our eyes on the residents for any possible adverse drug reactions. So I think, and I agree with Josh wholeheartedly, technology will go a long way. Some of these machines can be expensive, but many of the pharmacies that our independent residents use also have supportive tools like telephone apps that they can download and use as reminders for refills, or some counseling that's available even at the counter or over the telephone by retail pharmacists. Thanks, Josh.
Great. Thank you. Another question that came in addition to downloading the slides, are the forms that you shared today available anywhere?
This is Josh. Those are all examples of internal forms that we've used. I'm more than happy to share them. I'll defer to you, Lois, on the best way to facilitate that, whether that's sending them to you to upload or if people want to contact me directly. But I'd be happy to share them with anyone who's looking for a copy.
Sure, great. And another question we had was, we don't always have a nurse that follows us. Example, we have no night nurses in the building. There are only STNAs, and we lock our keys in our cart and have a security lock box with the extra set of cart keys. Is that okay to do it that way?
So I want to make. I assume we're talking about the issue of security, and in particular with our controlled substances. No nurse in the building, only STNAs. We lock our keys in our cart and have a security lockbox. I guess I'm trying to think through this. This is a great question. The issue is going to be, of course, that the key was controlled from the outgoing nurse to the oncoming nurse. And I'm not sure from the question what state they're in, so whether or not you could have your non-nurses involved in that. I'll be frank, it doesn't sound perfect, because the problem you have is your off-going nurse is not going to be able to do a count with your oncoming nurse, the way that Nancy described earlier. So let's say, for example, the off-going nurse signs everything looks good, puts the keys in the box, and they stay there until the next day. To be honest, if the oncoming nurse was wanting to do some drug diversion, she could take some of those controlled substances, and then you would have kind of no way to prove who was telling the truth. You get into a he said, she said. So it's not ideal. You ideally want those controlled substance keys, the second lock keys, to pass from person to person each shift. And obviously, I don't know all the details of that particular community, but I would really strongly recommend looking for a way to have that person-to-person pass-off.
Okay, great. Thanks a lot. Unfortunately, we're out of time. We had a lot of great questions, and anyone who didn't have their question answered during the webcast today, the speakers will follow up with you to provide the information that you need. and we hope you enjoyed today's webcast. Remember, this session will be available shortly to listen to again online, so if you'd like to listen to it again, or if you have a colleague who would benefit from the information, please write down this web address that you also see on your screen, mcknightseniorliving.com/May11webinar. Please remember that accrediting bodies dictate that CE credit will be given only to the people who attended this live broadcast. We'd like to give a special thanks to Josh Allen and Nancy for taking the time today for us to frame this important issue in an understandable way for senior living providers. And we'd also like to thank Omnicare, a CVS Health company. You can visit omnicare.com. And thanks, everyone, for listening today. Your questions were outstanding, and I'm sure helped fellow listeners gain an even better understanding of this issue. Once again, thank you for tuning in. This is Lois Bowers from McKnight Senior Living.